Hello, good morning, everybody. It's 9:30, so let's start. Today is the third day of the ICC 2024, so welcome. We're going to have a very important keynote lecture entitled Antimicrobial Resistance and Immunocompromised Patients, Past, Today, and Tomorrow. I'm Dr. Regina Burba from the Philippines. I'll be your chair this morning. And I have the distinct pleasure of introducing our keynote lecturer today. Professor Murat Akova is Professor of Medicine in the Infectious Diseases Department at Hacettepe University School of Medicine in Ankara, Turkey. Most importantly, he has served in several working groups on antimicrobial treatment in various societies across the world. He has Professor Akova is a past president of the SMID and is the current president of the International Immunocompromised Host Society. Dr. Akova's scientific research interests include infections in immunocompromised hosts, prevention of infection, and antimicrobial resistance. So everyone, my colleagues, please help me welcome Professor Murat Akova.
It's a real pleasure to be here. This is my birth town, actually. I was born in Istanbul and raised here and then went to university and eventually moved to Ankara, where I'm working right now at Hacettepe University. So this is a very special place, and I hope during the last couple of days you enjoyed your time in Istanbul and you're still enjoying it, and you are going to enjoy it until the end of the conference. I would like to thank the organizers for inviting me for this talk. And as Professor Burba was explaining, that within the following half an hour, I will try to explain you and try to make kind of a journey from the past, today, and a little bit of future about the antimicrobial resistance and immunocompromised host. Oops, this doesn't work anyway. So, these are my disclosures, some part of it already mentioned by Professor Burba, and this is the outline which I'm going to talk about. So in the context of past, present, and future, I will try to say a few words about the epidemiology of antimicrobial resistance globally and regionally, and in the context of cancer and transplant patients, and try to discuss with you about the current recommendations for management of infection in immunosuppressed. These are going to be basically stem cell transplantation in leukemia patients. This is my special interest, and there have been a recent unpublished guidelines by the European Conference on Infections in Leukemia group. This is the ISIL group, so I'm going to try to bring forward these new guidelines, and then a bit of words about what to expect from future on this topic. So let's start with the global epidemiology. I'm sure most of you are aware about this paper, which is recently published in September 2024. It's the largest study ever which has been done about the bacterial antimicrobial resistance. So it's a story of the last 30 years, and it's a systemic analysis which includes also a forecast until 2050. So you know the previous work about antimicrobial resistance and the predictions for 2050, which is expected more than 10 million deaths of antimicrobial resistance by 2050 if certain measures are not taken. So this paper somewhat is the scientific background of these assumptions. And as you see the figures there have been more than 500 million individual records or isolates and almost 20,000 study location years. Now, it's all about the mortality, actually. So if you see the comparison, so the AMR on the left-hand side of this slide is compared with no infection, and on the right-hand side, it's the sensitive bacteria, so resistance versus sensitive. And then you see the figures there. The green one is figures from 1990, and the dark blue ones is from 2020. Right here, and I would like to draw your attention you see the age group, the very young age group, there have been significant improvements over these 30 years in terms of mortality. So mortality significantly declined. But if you go to the elderly, right here, the upper part of this slide, you see the 2021 figures significantly increased. So the mortality has been increased, either compared with the no infection or sensitive bacteria. So this is important, I guess, because, you know, because of the immunosenescence, even without any underlying diseases, these people are dying because of AMR in the elderly group. And then this is the past, present, and future. So these are the data actually from 1990, 2021, and 2050. So you see the differences of the death rate attributable to AMR. Well, there have been significant improvements if you look at the data actually between 1990 and 2021. So the colors are getting blue, which indicates improvements in terms of mortality. But if you look at 2050, there is a grim picture. So the colors are getting more red or orange, which indicates increased mortality in this group. And this is the another figure over these 60 years, including predictions of course for 2050. This is the death attributable to AMR. And again, you see the age group, the upper part right here, it's the elderly group. So the increase of mortality in this age group is going to be significant if certain measures are not going to be taken, of course. So this is an excellent paper, but from the immunocompromised part of the world, it indicates that the elderly group, those group who are over 50, and particularly over 70 and over, there is going to be more death about for antimicrobial resistance. And then this group, of course, is going to prone more immunosuppression due to various diseases, or even without diseases due to immunosenescence. Now turn to the past a little bit. So if I'm asked to show you a single slide about how the whole story started about immunosuppression and infection, I think this is the slide that I'm going to show you. So this is almost 60 years ago in Annals of Internal Medicine. This person there, Professor Gerald Body, who was working at that time at NIH in the United States, he published actually a very simple observation. And you see on the right-hand side of this slide, this is hand-drawn picture, a very simple picture, started the whole story. So this was the beginning of the story between the relationship between neutropenia and the mortality. So you see, it indicates a very simple information saying that if you have lower numbers of neutrophils in your blood, the incidence of infection will significantly increase. So this is the concept of neutropenia. Less than 500 polymorphonuclear leukocytes in your blood, you're going to have infection. If the number is below 100, there is going to be significant bacteremia, and there is going to be significant other types of infections. So a tribute to Gerald Body, who perished a couple of years back, actually. So he was the man of or the father of the febrile neutropenia. Then the EORTC trials came. This is the European Organization for Research and Treatment group, and there was a group of infectious diseases which unfortunately was closed down a couple of years back, but they did tremendous trials during 1970s, 80s, 90s, and early 2020. And if you look at the slide, those of you who are already involved in the area, you're aware of this, but the importance of, so by the way, these are the bacteremic cases. And the bacteremia in 1970s until mid-1980s was caused basically by gram-negative bacteria. And in mid-1980s, then the gram-positives became dominant because of the indwelling catheters that the patients are being used, inserted at that time. But then at the turn of the century, which was the last studies of the EORTC group, then the gram-negative bacteria started to emerge again. And this was because of the antimicrobial resistance, of course, because at the turn of the century, we started to see those bacteria with carbapenem resistance, ESBL-producing bacteria, and various mechanisms of gram-negative resistance to a variety of antimicrobial therapy. So 10 years ago, exactly, we published this paper. This is the group of ISIL. This is the European Conference on Infections in Leukemia, this was a group of combination of these three organizations, EBMT, EORTC, Immunocompromised Host Society, and European Leukemia Network. So there were approximately 40 scientists throughout Europe and the Middle East. They came together in 2005, so almost 20 years ago, and started to create guidelines every other year. So that was the first guideline about antimicrobial resistance in cancer patients. So exactly 10 years ago, this is the picture in Europe. 44% of patients infected with gram-negatives, particularly, right, you see here, Enterobacteriaceae, 33%, Pseudomonas aeruginosa, and the others, and the rest were gram-positives. Well, now, in 2024, WHO recently published this list. This is the bacterial priority pathogens. They updated, actually, the previous list. And there are 3 microorganisms which are standing right here: Acinetobacter, Enterobacteriaceae, ESBL positive, and also carbapenem resistant, and both of them. And then the Pseudomonas aeruginosa right here. And these 4 microorganisms are critical in our immunocompromised host population, not only the antimicrobial resistance, but also causing mortality and causing significant infections in this patient population. So now I will switch to a particular problem, which is carbapenemase production in both ESBL, in both Enterobacteriaceae and Pseudomonas aeruginosa, and ESBL production, and try to give you a fresh idea what's going on globally about this antimicrobial resistance problem. So this is the KPC producing Enterobacteriaceae and Pseudomonas aeruginosa. So you see it's widespread in Europe, in Southeast Asia, and both North and South America. Well, I would say, fortunately, my country is spared of KPC. We have only a few cases of KPC in Turkey. It's recently started to emerge, but still less than 5% of our Klebsiella are producing a KPC, and less frequent in Pseudomonas aeruginosa as well. Whereas this country is the country of problem with OXA48 type of enzymes. So this was a Turkish creation that was described first in Istanbul at the turn of the century, and then spread to North Africa and Europe as well. But you see it's widespread, but particularly it's a problem in Europe and North Africa. There are cases throughout the world, but still it's a European problem. Then, of course, this is the real emerging problem. It's the metallo-beta-lactamases, and as you see on the left-hand side, it's the Enterobacteriaceae, and on the right-hand side, it's Pseudomonas aeruginosa, particularly NDM in Enterobacteriaceae and Vim type of enzymes in Pseudomonas aeruginosa. Well, Indian incontinent, of course, has a huge problem with this. Well, NDM was emerged in Indian subcontinent and named after this, but it is emerging. Now, what is the context with neutropenia and the carbapenem resistance in that case? Well, that paper was not the newest one, published in 2017, but it shows us these carbapenem-resistant bacteria are spreading also in the neutropenic cases as well. And these dark countries are those countries where neutropenic patients are found to be infected with carbapenem-resistant gram-negatives in bacteremic cases. And these are the distribution of carbapenemases in hematological malignancy. So you see on this map, and I refer you to this paper actually, I'm not going to go into detail, of course, but they are trying to match the different type of carbapenemases in neutropenic patients with hematological malignancies, where the data is available, of course. So you see, particularly in Europe, the Southern Europe, including Turkey, Greece, and Italy, is one of the prominent countries, and then North America, South America, and then the Southeast Asia. So it fits exactly what I have described with the global picture of these enzymes. It also fits in the febrile neutropenic cancer patient group. And then you can match it with the leukemia incidence and the carbapenemase endemicity. So the axis indicates the situation of carbapenemase enzymes in the region, and then the darker color indicates the higher prevalence of leukemia in those countries. Well, Turkey, North America, Middle East, and also some of the European countries, you see a very high incidence of leukemia, and also the endemicity situation of these carbapenemase enzymes has been described. Well, of course, I mean, this is natural, isn't it? If you have a problem in your patient population with the carbapenemases, carbapenemase-mediated resistance, obviously you're going to have the same problem in your immunosuppressed patients or in leukemic patients or in neutropenic cases as well. Now, let's talk a little bit about the ESBL, so the extended spectrum beta-lactamases. I just put it after the carbapenemase because it's even a bigger problem in our global community, but also in our immunosuppressed patients. So this meta-analysis has been published a while ago, and it covers 22 studies, 5,600 bloodstream infections, and looks at the prevalence of the ESBL gene in gram-negative bacteria. So the overall incidence is 11% throughout the world, but they found 7% in Europe, Eastern Mediterranean, and South America, which is a little bit, less, I guess, because in my institution, if you go to the ICU, this figure would be these days more than 50%. But that was the case, and the highest numbers are coming from Southeast Asia. And they described a trend, and they said over the time, they predicted a 7.1% increase over the time. And that was 7 years ago, a paper. So probably the data are coming from 10 years ago. So 10 years ago, they predicted a 7.1% annual increase. Well, look at this trial, for example. This trial came in 2022, so 5 years after the publication of the previous paper. And this is a study from Barcelona, a large cancer center. So Carolina Garcia Vidal, who was chairing the session, this is chairing the department, they published a large number of patients with bloodstream infections, 44% of them gram-negative bacteria. And look at the figures here. 21% of ESBL producer. It was predicted 7%, so 3 times more. And obviously, well, probably the starting point was much higher, but 1/5 of all organisms were producing an extended spectrum beta-lactamases. The same in Klebsiella pneumonia. In Pseudomonas aeruginosa, there was this MDR or XDR pattern. So in this specific group of immunocompromised neutropenic patient population, there were higher figures in those. And then they described a trend over the years, starting from 1990s till 2017. So that was 20 years prediction. And particularly, they had a problem with Pseudomonas aeruginosa, not with the Enterobacteriaceae, but the resistance in Pseudomonas aeruginosa has been increasing over the years. Well, this is my institution. This is the figures during the last decade, actually. And if you look at all these pathogens, including overall MDR pathogens, there was a significant increase, statistically significant increase during this last 10 years, and then all these carbapenem-resistant, ESBL-resistant, colistin-resistant phenotypes are increasing as well, although not statistically significant because our background resistance rate is quite high. I mentioned ESBL. I mean, if you go to the ICU in my institution, in Klebsiella, for example, we have approximately 50% of carbapenem resistance these days. Most of them are OXO-48 production. So it's a huge resistance rate, but it's still increasing over the time. As I mentioned earlier, I'm not going to say a lot of work out of febrile neutropenia in hematological cancer or stem cell transplant patients, and this is the only one of the couple of slides that I'm going to show you about solid organ transplantation. So this is a very recent paper published this summer. It shows us the different types of resistant patterns throughout the world and the prevalence of, for example, here, this is carbapenem-resistant Enterobacterales. This is Pseudomonas aeruginosa, this is Acinetobacter, and you see the darker the color, the higher the incidence, of course. In various countries where the data are available, these type of resistance exist in these type of microorganisms. And if you look at in particular different types of solid organ transplantation, you see the liver transplantation and the heart transplantation have the highest incidence of this antimicrobial resistant pathogens. And if you look at the ESBL, for example, in kidney transplants, is the leading type of transplantation, and this is obvious. This is ESBL positive E. coli probably, and in different types of transplantation, so you see a bit of different type of antimicrobial resistance patterns exist. Now, the last bit of my talk, I'm going to try to give you the update of what has been discussed in the recent European Conference on Infections in Leukemia. So this year, it was in September 2024, and as usual, it's in France and Nice. So this is the group of bacterial febrile neutropenia. We also discussed the duration of therapy and new drugs. So there are subsegments of this conference, and this is the 10th of them. So this is an update of the 2011 guidelines, and this is the new guideline. Well, by the way, I created this QR code here. If you scan this QR code, you can go directly to the website, and the guidelines now are in public opinion, so you can check the guidelines and then send your opinion and send your suggestions on the website right here. So, as I mentioned earlier, these are the 4 institutions that are constituting the ISIL group. So first, the epidemiology of resistance that we have discussed. So this is the latest update of the epidemiology, because we screened all these trials until 2024, 42 studies, and you see on the right-hand side the epidemiology of the resistance throughout Europe. And again, you see the ESBL and the carbapenem resistance right in the bottom. It's the highest endemicity in the Mediterranean and the southeastern European part, where the resistance rate is quite high. Well, this is the map from WHO. This is 2021 data. This is older data, and it shows a very similar picture. So if you're living in Greece, Italy, in Turkey, the likelihood of having an AMR pathogen is quite high. So this guideline is based on several questions asked for these febrile neutropenic cancer patients. So the first question is about on colonizing bacteria, and as you see here, there are 4 questions. That means that if your patient is colonized one of these resistant bacteria, what are the consequences? So the first question is there an increased risk of subsequent bloodstream infection if your patient is colonized with resistant bacteria? And the answer is yes for gram-negatives, no for gram-positives. So if your patient is colonized, then you should expect a resistant bacteremia. The second question is there a correlation between inappropriate antimicrobial therapy and the mortality due to resistant bacteria? Again, the question is yes for gram-negatives, no for gram-positives. We know that because gram-positives do not affect mortality. Decolonization, microbiota transplantation, or prophylactic antibiotics, well, there is no answer. Actually, there is limited evidence. And about the novel beta-lactams, particularly beta-lactamase combinations, there are limited data, particularly with ceftazidime avibactam. Well, from now on, I'm going to show you some grading, and unfortunately, I don't have time to go into detail, but this is the grading which has been created by an ESCMID group several years ago, working on the same topic, and ESIL uses this grading for this topic as well. So A has the highest recommendation, strongly support, and 1, of course, evidence from a properly randomized controlled trial, and the rest of it spread different opinions. Now, the other question is whether monotherapy or combination therapy should be used. And unfortunately, if you look at this, there is not very much evidence of using combination therapy for the empirical therapy. Well, the group described certain conditions depending on the literature data. It's basically gram-negative bacteremia and pneumonia, but these data are coming from the high resistance settings, which might work for these situations, but mostly it's monotherapy. And if it's a gram-positive infection, there is no need to use combination therapy. Now, from now on, I'm going to show you what is the difference between the earlier version and the next version. So between 2014 and 2011, actually, and 2024. So those of you who are aware of this suggestions of previous ISIL, there were some recommendations saying that there is an escalation approach. So if you are living in a country with low resistance setting, no previous colonization, no previous antimicrobial exposure, you can start with a narrower type of antimicrobial therapy and then escalate it if it's necessary, if the microbiology results indicate. So basically there is no change. So you can use in these patient population an anti-pseudomonal beta-lactam antibiotic or beta-lactamase inhibitor combination. Whereas in the escalation strategy, there have been some changes, specifically addressing sepsis and septic shock patients, and instead of colistin beta-lactam plus rifampicin combination in the previous guideline, now the new guidelines indicate the new beta-lactamase inhibitor combinations, particularly ceftazidime-avibactam in this setting. And these are the indications for those new beta-lactam, beta-lactamase inhibitor combinations. So for example, KPC producers, ceftazidime-avibactam, meropenem-veborbactam, or imipenem, silastatin, relebactam, or cefiderocol can be a choice. For OXA48, it's ceftazidime-avibactam and cefiderocol. And MBL producers, you should add aztreonam to ceftazidime-avibactam. Well, actually, aztreonam-avibactam has recently been approved, but limited availability, so you can use any of these antibiotics. And in Pseudomonas aeruginosa, it's basically 4 antibiotics, as you see here. Ceftolozone tazobactam is the highest evidence, then ceftazidime-avibactam, imipenem, relebactam, or cefiderocol. Now, within the last 2 or 3 minutes, I'll say a few words about the future. Well, we recently published this in Clinical Microbiology and Infection. It's still in press, but it's available online. So it gives us an explanation about the current problems and what is the future holds for in respect of hematological cancer, hematopoietic stem cell transplantation. So my last and conclusion slides are coming from this paper. First of all, what are the shortcomings we have in this patient population and what we need in future to treat and manage these patients probably? Well, we still need reliable tools to determine the risk factors for infections in colonized patients. I showed you that in colonized patients, particularly with gram-negative bacteria, you have a higher expectancy of bloodstream infections caused by these bacteria, but still we don't know what kind of risk factors are affecting because there is still a considerable group of patients who are colonized but do not develop bloodstream infections. So what is the differences between them? We need some trials for that. And again, monotherapy versus combination therapy. It's been a great debate. I mean, in many countries, so people say you need monotherapy, that would be sufficient. That was said for carbapenems in the past, and that is being said at the moment for new beta-lactam, beta-lactamase inhibitor combinations like ceftazidime-avibactam, for example. Monotherapy is sufficient. Does that true? There are no randomized controlled trials, so it's just the presumption that it would work, but we need randomized trials. And then, of course, it brings us the problem of difficulty of organizing randomized controlled trials. It's very difficult to do this, not only for the economical reasons, but for the ethical reasons as well. For example, in an ideal world, you are going to do a randomized controlled trial, treating a patient as early as possible empirically, and then delaying the treatment in the comparison group, which is impossible to do this in a febrile neutropenic patient. You can kill easily the control group of patients. So instead of that, there is a new strategy which is called Target Trial Emulation Framework, which means it gets the data from the observational data available, and from these data you can emulate a randomized controlled trial. Of course, it's not the ideal exact randomized controlled trial, but you can use these data to make some predictions. So this type of complicated strategy can be used in this group of patients as well. Then we need to know and determine the exact cutoff level of prevalence of resistance. So for example, let's say in your institution, you have a rate of ESBL positive E. coli and Klebsiella pneumonia around 10%. So in your empirical therapy, would you consider these patients to be covered in your empirical therapy? Well, of course, if it's 50% in my institution, we have to cover. There's no opportunity because it's like flip a coin. But in 10%, we don't know. We don't know the exact cutoff point. There is an empirical suggestion around 20%, but nobody knows why it's 20% because the author of the paper said this. So it has to be studied. Need randomized controlled trials. And then, of course, the new agents. I mean, I have said a few names about the new beta-lactamase inhibitors can be used, but of course there have been no randomized controlled trials in this particular group of patients, so we need trials for this one as well. And finally, nowadays you cannot do anything without artificial intelligence and analyzing big data, so we need to incorporate these type of strategies into our neutropenic patient population or immunosuppressed population to analyze data in order to have precision and personalized medicine. I think I'll stop here. Thank you very much for listening and entertain any questions you might have. Thank you.
Thank you, Professor Akova, for navigating us on the AMR burden among immunocompromised patients, and he talked about the elderly, the neutropenics, cancer patients, including those with hema-oncologic conditions and solid organ transplants. So this is a keynote lecture, and there's really no time for open forum. So, but if you do have any questions, please approach Professor Akova. Let's give him a big hand. Thank you very much, Professor.